Welcome to the Compounding Center Connections podcast, where we talk about different health conditions with our partner practitioners. I'm your host, Jay Gill, a compounding pharmacist from the Compounding Center in Leesburg, Virginia. At the Compounding Center, we collaborate with practitioners, create custom medications to help our patients get better. So in today's episode, I'm super excited to have Dr. Benjamin Gonzalez with us. He's better known to us as Dr. G. He's the medical director of Atlantis Medical Wellness Center in Silver Spring, Maryland. So welcome, Dr. G.
Well, thank you. Thanks for inviting me. Appreciate it.
So in this episode, we're going to talk about weight loss, but I like the term that you've coined even better, metabolic repair. So before we get started, Dr. Gonzalez, could you introduce yourself, your practice to the viewers and listeners?
Well, sure. I'm the founder and medical director of Atlantis Medical Wellness Center in Silver Spring, Maryland. If you know where the FDA is, you stand on top of my building and you look southwest, you can basically, I can spit off the building and hit the FDA. So that's where I'm located. I don't do that every day, but every once in a while. I founded Atlantis in 2005 after I retired from the military, 24 years active duty as an emergency medicine physician. I was trained under the auspices of Dr. Andrew Weil at the University of Arizona in medical school, and always had the integrative medicine, functional medicine mentality, even through emergency medicine. I specialize in women's health, metabolic repair, weight loss, and hormone management.
Awesome. And so simple disclaimer for everyone. The information discussed today is for information purposes only. It's not for any diagnosis or treatment. So, Dr. G, explain what do you mean by metabolic repair and why we should be focused more on metabolic repair than on like weight loss or weight loss program that we hear about.
You know, this will make sense. This should make absolute sense. You know, we talk about the advice of exercising more and eating less, right? We tell people to exercise more and eat less. How well has that worked over the last, 30, 40 years in this country? I mean, our obesity rates have escalated to the point of I'm worried about our population. And we talk about weight loss, we study weight loss, all the studies are on weight loss, studies about weight loss, but very few studies on the maintenance of that weight loss.
Yeah.
And that's frustrating. I'm passionate about this subject because my mom weighed nearly 300 pounds most of her adult life. She was hurt by the drug fen-phen. Talk about that a little bit later. She survived. That's the resiliency of the Swedish, that's her Swedish background. But she survived, still alive today, survived 2 heart surgeries because of that drug. I have cousins younger than me that have passed away from their obesity issues. My little brother, who ran cross country in high school, over 300 pounds, nearly 300 pounds, over 300 pounds. Now and has just struggled most of his life, all of his life with weight. And I'm passionate about this because we have been wrong in medicine about talking about weight loss. What we should be talking about is your metabolism and metabolism maintenance and the management of that metabolism. We think about calories in, calories out, but we don't think about all the things that support our metabolism. We don't think about the hormones. We don't think about insulin resistance and insulin and glucose metabolism. We don't think about our gut health. We don't think about all these different things that support weight loss. And that's what we should be managing. Turns out in my weight loss center, the very first thing that I tell my patients is that I don't care about your weight. The only reason why I measure people's weight in my clinic is because they expect me to. What I care about most is their metabolism, the markers of metabolism, waist and height ratio, and body fat percentage, all markers of metabolism. So if we manage metabolism, then you can manage the long-term success for improvements of those weight loss. And that's what metabolic repair means.
Awesome. So we're going to touch upon some things you just mentioned about. Now, the hot drugs, right now, you got semaglutide, you got tirzepatide. That's all we hear about. And as I mean, as a compounding pharmacy, and I have personal friends, and I know so many people that are on it. Okay, that is the tool that everybody wants right now to lose weight. Where do these drugs fit in your metabolic repair program?
Yeah, I'm like you. I mean, in the decades as being a physician, I've never been asked about more about a single drug than I have these class of drugs
Yeah.
on a daily basis. Friends, family, patients. I mean, you hear more about it. Heck, you can find these drugs everywhere. You can find this drug on Groupon, for the love of God. That's just, it drives me nuts. And we don't really understand what I mean by we is that the healthcare system really doesn't manage this, how we manage weight loss drugs very, very well. These class of drugs, the GLP-1 agonists, they promote weight loss primarily through their action on the incretin hormone pathway, which influences glucose metabolism and appetite regulation. These medications mimic the effects of the naturally occurring glucagon-like peptide that's found in your gut, released from the intestines after eating. These GLP-1 receptor agonists work by binding on these receptors, not only in the pancreas to enhance insulin release, but also glucagon suppression, but also these receptors in the brain that allow for hunger suppression. They also slow gastric emptying, leading to prolonged feeling of fullness after eating. And interestingly, these GLP-1 receptor agonists, the semaglutides, the tirzepatides, act on areas in the brain involved in appetite regulation, reducing hunger and caloric intake. So what I like about these medications and metabolic, in the context of metabolic repair, to answer your question, is that it helps enhance your body's ability to manage insulin resistance and glucose response to insulin. That's
Okay.
one, and that's what we're looking for, because insulin resistance basically is the cause of fat retention, obesity. And one of my favorite things to say in all my lectures is that insulin resistance is the cause of all chronic diseases, non-infectious chronic disease processes. And to manage metabolism, we need to manage insulin resistance, and these drugs help do that and promote that.
Gotcha. Could you touch upon any side effects that you come across? And because I personally say you got to respect the side effects of this drug, to all our patients. So, any side effects that you come across from your patients that are of concern?
Oh, absolutely. So when we talk about side effects in general, that's kind of a trick question. Side effects being the kind of side effects that are non-urgent or not dangerous, and then of course the side effects that are dangerous, right? So we talk about two different kinds, and frankly, the number one side effect of these medications is nausea. As the number one non-emergent side effect from these medications. And you hear a lot about nausea, because these do slow down gastric emptying, which is one of the mechanisms of the weight loss. It improves your satiety. So nausea, and the reason for that is you get these medications, you take this medication, it increases that hormone in your gut that's not normally increased so quickly. And then you get this nauseous feeling. So that's the most common. As far as dangerous, honestly, I have not in the years. I introduced these drugs in 2017 at the Boston Weight Loss Symposium, and been using these medications for that long. And I've not once seen any long-term issues with that. And there's not much reported in the literature either of long-term dangerous side effects. So number one side effect is nausea.
Yep, same here. Nausea and constipation, two key things that we always give answer phone calls on. Now, so most of us, including me, we have that stubborn 20 pounds that we want to lose, right? We've gotten older, it's gotten harder, and this is a tool in front of us to kind of use to get that 20 pounds, to lose that 20 pounds. What are your thoughts about using it in that manner, the GLP-1s?
Here's the part about metabolic repair that the general population certainly has a difficult time understanding, but that the healthcare system doesn't understand. When I said that I don't care about your weight, I really meant that. I don't care about weight loss, because what does weight loss actually mean? It means the loss of both fat and muscle. And your metabolic engine, that thing that keeps you in a good place, that metabolic engine is muscle. And managing muscle is the key for all of this. So, and I'm sorry, ask me the question again, because I know I'm going to get distracted with this.
Well, I mean, because we want to lose 20 pounds,
Yeah.
this is what we kind of think about saying, okay, I need to get over the hurdle here, and this is going to help me getting semaglutide and tirzepatide. Is it really meant for that? But you're explaining you got to understand your metabolic, the metabolism, how to
Yeah,
do.
we don't want to just lose 20 pounds. We want to lose body fat percentage. We want to lose pounds of
Yeah.
fat, not pounds of muscle. And that's part of honestly, that's part of the issues of weight loss studies in general, is that we talk about in the context of absolute numbers of absolute weight loss, when we should be talking about the metabolic markers, the markers of metabolism. And so we want to lose, these drugs are not meant for just weight loss. This is not a cosmetic, these drugs are not meant for cosmetic weight loss. What I mean by that is you shouldn't be using these medications to lose that weight for your wedding dress or for your vacation or for the summer. These are for individuals that have metabolic issues that include insulin resistance, that include all the inflammatory issues that are associated with metabolism. These are for those individuals. And when I was first using these medications, of course, mostly for my diabetics, my type 2, my insulin resistance patients that weren't diagnosed with diabetes, but had absolute insulin resistance. And that's a whole nother lecture, by the way, insulin resistance, diabetes, and the definition of insulin resistance and diabetes. But the bottom line is these medications are meant for those individuals who have metabolic issues that that can be managed through weight loss. And most, as I mentioned, most chronic diseases, insulin resistance, can be managed through metabolic repair, and that's what we're trying to do. So 20 pounds, yeah, it depends on the individual, right? For my little brother who weighs over 300 pounds, we're talking about hundreds of pounds, 100 pounds, right? But for those individuals that their body fat percentage is less than, let's say 25, or in the standard of, we talk about BMI, these drugs are meant for those individuals that have obesity, their BMI greater than 30, or greater than 27 with some sort of underlying metabolic problem. And that's what these drugs are. Those are who these drugs are meant for. Now, do I modify that? Certainly, I definitely do that, because I don't want to wait for that individual to be off the cliff before I manage them. If I see them headed towards that metabolic issue, that insulin resistance, diabetes cliff, or that obesity cliff, I want to stop that. And yes, I do use these medications for those individuals.
Gotcha. So, I've also heard you use the term nutritionize yourself. Okay. So can you explain to us what do you mean? Because I think this at one of your lectures that I was at, you were talking about a lot about the metabolic markers and certain and things like free fatty acid oxidation. Could you touch upon that a little bit?
Yeah, absolutely. So it was interesting at this conference that I just attended in LA, um, it's an international conference of gym owners. And, they talk about calories in, calories out, about what I mean by nutritionize is that we talk about how many percentage of calories of protein and fat and carbohydrates. and we nutritionize our diets so much to the point that we're missing the point of what each individual needs. And each individual is different. A 20-year-old is different than a 40-year-old is different than a 70-year-old, right? And their metabolic needs. A woman who is 30 years old, who has not had a pregnancy or a baby, is a very different woman who is 30 years old and has had 3 babies and 4 pregnancies, right? These are different metabolic. So to nutritionize each of these individuals is not very, it doesn't work in managing their metabolism. So what we need to do is be personalized to these individuals. We need to look at their biomarkers. We need to look at their specific magnesium red blood cell levels. We need to look at their specific insulin markers, and then change their diet according to that. The big thing, of course, is intermittent fasting, right? Intermittent fasting. Frankly, I just wish people would fast between meals. That would make me happy.
Yeah.
If we could just get people to fast between meals, that in and of itself would go a long way, rather than depending so much on how much protein someone's taking, or how much carbs, or how much fat someone is taking in. I think that would help a little more. So don't over nutritionize your diet. Rather, be more specific and personalize your diet to who you are as that individual at your age and your gender.
Okay. And you touched a little bit about some labs. Can you repeat that again? What are some important labs that you look at? I remember you talking about magnesium, zinc, and something else. Could you talk to us a little bit about that?
Absolutely. One of the mistakes we make, first of all, in healthcare systems, we think too linearly, right? We think 1 + 1 is 2, 2 + 2 is 4, when in fact in medicine and your physiology, 1 + 1 could be pi, right? So, and we hang our hats up on certain labs, the basic labs, and we tell what's the most common thing that a patient hears from their doctor at their annual visit. Patient A, everything is normal.
Yeah.
When in fact, that's kind of it's not a lie, but it's misdirecting you. First of all, hang your hat up on labs. And labs is just a small picture of who that individual is, right? Just a small picture. You have to clinically correlate these labs, right? So, and one of the mistakes made in these types of, when people hear me lectures, they hang their hat up on what I say about, okay, you got to check your magnesium. But what does that actually even mean? The bottom line is, remember I said about metabolic repair? You got to look at the metabolic markers of health. And so what are some of those things? Hormones, all hormones. At any age, part of the problem is that when a 25-year-old goes to see their primary doctor and they're doing all right, and their doctor says, oh, we don't need to get your hormones. You're young, you're doing fine, everything is fine. It's like telling a 25-year-old smoker who's doing quite well, can run a mile in however long he can, and do very well at 25 years old smoking. It's like telling them, oh, you're absolutely fine. Let's wait until you have a problem before we tell you to stop smoking, right? So same idea. It's the same concept. So basic labs is hormones, basic micronutrients that include magnesium red blood cell levels, not just magnesium serum levels, but magnesium red blood cell levels, which is a more sensitive marker to your magnesium levels. Insulin resistance. I talked about insulin resistance, not just your fasting glucose, and not even just the hemoglobin A1C, that marker, that 3-month marker of blood sugar levels, but rather your insulin resistance marker, so free insulin levels, the HOMA, the homeostatic metabolic assessment of beta cell function, the HOMA marker, HOMA, which you can find at LabCorp. You can get that LabCorp request or any lab. The LPIR score, or the lipoprotein insulin resistance score. That is a nuclear magnetic resonance marker that you can get, gives you the biomarkers, more detailed look at lipid profiles. And those are easy labs to get, that give you a better look at what's going on with that individual's blood sugar and insulin resistance. So those are some of the markers, including inflammatory markers like the high sensitivity C-reactive protein, or the cardiac C-reactive protein, another good marker. So all these are some of the markers that I get in my baseline. Not waiting for someone to be really sick before I get those markers, but my baseline metabolic panel.
Got it. Okay. So, I'm gonna ask your opinion on continuous glucose monitoring, systems because I personally use them, and the data that I got for 2 weeks was amazing to see.
Wakes you up, doesn't it?
Yeah, it wakes you up what it's doing to your blood sugar. Do you, I almost feel like that should be prescribed or used as a tool when somebody is starting that metabolic repair journey. What are your thoughts on that?
Yeah, that was a big question in this conference I was at about CGMs, and it's a difficult because honestly, I think everyone would benefit with the CGM. The problem is, of course, cost and availability, and those who actually need it. But again, this is one of those things. We wait for someone to become a diabetic.
Yeah.
First of all, the definition of diabetes is wrong, and what we normally do in our healthcare system, it's wrong. If you read anything that has to do, if you're listening to this, write this down. Dr. Joseph Kraft. Kraft is in Kraft cheese with a K. Dr. Joseph Kraft, look at his definition of insulin resistance diabetes, because that's my standard of diabetes insulin resistance, is what Dr. Joseph Kraft in his studies, not just looking at postprandial or after eating blood sugar levels, but looking at after eating insulin levels, and what happens with your insulin versus glucose. So anyway, I'll distract, but back to the CGMs. I think they're very valuable. I firmly believe that if anybody who is obese or have comorbid issues should have a CGM so that we could get a better control of their insulin resistance. It does wake you up to understand what's going on with your blood sugars. And data is important, right? When you see in front of you that people will react, my cholesterol is really high. Oh my gosh, I need a statin or lifestyle changes, all these different things, right? But we don't really talk to our patients about, oh, your insulin resistance is high. We just say, oh, your hemoglobin A1C is totally fine. Everything is normal.
Yeah.
And we're wrong. We wait for the cliff, right? Wait for you to fall off the cliff. I think these CGMs help wake you up to who you are metabolically speaking. They're difficult to get for everybody. I wish it was accessible to everybody. Insurance doesn't pay for it unless you're falling off the cliff. But if you can afford it, if you can get it, you can have your doctor write the prescription for it, then yes, I think they're very valuable in waking you up to who you are metabolically speaking from the insulin resistance perspective.
Well, before we end this episode, could you share a little bit about your metabolic repair program? I know your success rate is really high on patients keeping their weight off. I forgot, it's the 3-day thing that you talked about. Could you talk to us a little bit about your practice, your program, before we end this episode?
So as you can guess by this discussion, my programs are not about weight loss. I don't really care about weight loss. I have no interest in weight loss whatsoever, even though I'm known as the weight loss doctor and we're a weight loss center. What our programs target is metabolic repair. And if we do that, if we improve your metabolism, the success for getting the weight off, or for keeping the weight off, the long-term success is much higher. So in our programs, we don't have one specific diet that's for everybody. Not at all. Our diets, our programs, our metabolic repair programs are targeted to be personalized for that individual. I kind of hinted to that about you can't tell the same 25-year-old the same thing you tell a 55-year-old. You definitely can't tell a postmenopausal woman to do the same thing that she did when she was 25 or 35, right? They're just not going to respond. So first thing we do in our programs is we get the biomarkers of health. And we look at those biomarkers, and then we guide you to whichever program, whether it be a ketogenic-like program, whether it be an an intermittent fasting-like program, whether it be a very low-calorie diet program. And we have very specific programs that do very specific things for those individuals. And we utilize the medications, the GLP-1 agonists, the GIP agonists, tirzepatide, semaglutides. We do utilize that, but not for everybody. And sometimes redirecting an individual's lifestyle choices, just doing just that alone, just getting people to understand to fast between meals, to eat a little earlier, to sleep a little better, to learn how to breathe. They lose that 10, 15 pounds and they keep it off. And then the most important thing about our programs is that the support. It's not just, here's your program, have a nice day, we'll see you when you gain your weight back. The aftercare is extremely important, and that's a very neglected aspect of weight loss in our healthcare system. It's a very neglected aspect of the studies done for weight loss. So, our programs are directed to as an individual, very personalized, and we treat you like an individual person that wants to get into a better place and stay there.
The aftercare is so important, and
It's
all
key.
these patients that have started on these GLP-1s, the hardest thing is to get off of them. And,
And a shout out to women out there. I'm telling you, you guys, you're the most ignored population in our healthcare system, the most ignored. If you're a woman of color, even worse. If you're a postmenopausal woman of color, you are the ignored individual in our healthcare system. And I'm saying this because I'm acknowledging this because our population is getting older and we're seeing more and more stress in our perimenopausal, postmenopausal patients than any other population type. And the stress isn't just coming from what you're naturally going through. Menopause, of course, is a woman transitioning from a powerful young woman to a more powerful woman after menopause. So, supporting you as an individual, I think, is the most ignored thing we do in the healthcare system, but it's what we don't do in our clinic and what we specialize in. I just want to shout out to that woman.
Well, great place to end this episode. Dr. Gonzalez, thank you for joining us today. I mean, you shared a lot of information with us. Now, how could someone reach out to you and how could they get in touch with you?
So all this information I talk about, you can find the different videos, different discussions on my Instagram. My Instagram is and then my name, all lowercase, Ben Gonzalez, BenGonzalez_MD. And that's the best way to communicate with me too, direct messaging. I have a team that follows my social media and Instagram in particular, and we respond within hours of direct messaging on that platform. My clinic, Atlantis Medical Wellness Center, their phone number is 301-622-2722, and let that individual know at the front desk that you heard us here, about us here. And then you can schedule a welcome to practice, 30-minute telephone conversation with patients all over the world. And you can, schedule a 30-minute appointment on the phone, and we can just see if it's the right fit for you, see where you are as an individual, right? And then, of course, the email is info at atlantismedcenter.com. Those are the best ways to communicate with me.
Great. And I'll make sure to put all that information in the show notes. And thank you, everyone, for tuning into the Compounding Center Connections podcast. We hope you found the information presented today to be helpful. If you have any comments or questions, please feel free to reach out to me at jay@compoundingcenter.com. Subscribe to our YouTube channel and our podcast channel, The Compounding Center Connections. Give us a 5-star review and stay tuned for future episodes. Thank you. Thanks, Dr. Gonzalez.
Take care. Thanks for having me.